Good morning, Dubai.
Good morning. Good morning, Dr. Hani. This is Dr. Mohammed Al-Mutairi. I'm the moderator of this session. Let me first introduce my panelists here. We have Dr. Abdurrahman Ad-Diri from Saudi Arabia, Dr. Daniel Willenman from Switzerland, Dr. Fahad Al-Oufi from Saudi Arabia, Dr. Hadi Abu Hantash from Jordan, Dr. Khalid Al-Saidi from Oman, Dr. Muhammad Kutub from Saudi Arabia, and Dr. Sivit Goroglu from Turkey. So our live case is from Glasgow University in UK. Our operator is Dr. Hani Iteba, Professor Consultant Interventional Cardiology at Golden Jubail National Hospital. So Dr. Hani, please introduce your team and give us the case that we will have today.
Great. Thanks very much for the invitation, and we're really delighted and privileged to be with you in Dubai. I'm sorry I couldn't be there face to face, but delighted to welcome you to our cath lab. The Golden Jubilee University National Hospital is the heart center for Western Scotland and the entire Scotland for certain national services. We really are important USP, NSB University.
Dr. Hadi, it's
and where we are,
main disease, like the
procedure affairs, Gary,
left main
David,
PCR,
Becca,
like the profession.
that, and of course, our just the Francis Gucci, the director, our CTU program, which is the associate director and the principal of our program. And as you can see, we're very proud of these two slides. So over the last the Golden Jubilee National Hospital has been in the fourth that top of the United Kingdom highest PCIs at our highest station at work. And we are affecting.
Dr. Hani, we don't hear you very well. I mean, the voice keep, interrupted.
We are requested to our knowledge 2 minutes ago. It was going well. I'll try to carry on.
Like
Because if David and the team police from your side could perhaps try to help us. But Mike,
but there is
I could hear so perhaps this slide can talk and pass on to Mitch quickly to just fill it in about source and activity that take up in the Golden Jubilee. Mitchell.
Which seems we're having technical problems.
Can we introduce the case, Dr. Hani? So we're told that they fixed the problem before we joined, but I think still there is a problem. Okay.
So I wonder if you can see the case, and I'll go very quickly. So the case is a 78-year-old male presented with worsening angina and had strongly positive exercise tolerance test with a positive troponin after the exercise tolerance test, admitted as an emergency with diagnosis of acute coronary syndrome, and that was earlier this week. He's a smoker, hypertension, diabetic, chronic kidney disease, GFR around about 47, 48, with paroxysmal atrial fibrillation. He's of average felt nothing alarming in his clinical examination, normal resting ECG, minor troponin rise, and as I said, normal liver function and echocardiography, preserved the ventricular function, no valvular heart disease. Next. And as you can see, he's on standard treatment of acute coronary syndrome and all the appropriate secondary preventive measures. Next. And as you can see, a large risk ECG changes for exercise test following the low workload, only 2.5 minutes. These changes last for more than 10 minutes after exercise. So we're going to show you the ad graph. You had, and you can show the ad graph now. So just the first one, please. maybe the first. So we burn the 3 wards first. Yeah. So you will see the moving imaging, but generally speaking, the patient had severe distal left main stem bifurcation, probably Medina 100, had moderate mid-AD lesion, minor circumference black disease, and so he had effectively chronic total occlusion, had recanalized by the artery, and that filled with retrograde filling via intralaterals. Angiogram was done earlier this week, and what you see here and what happened as per our policy of practice. Patient was taken off the cath the following day. We discussed this with the management at the heart rates in a repeat. Francis, would you like to carry on from here?
Dr. Hani, can we see just the diagnostic angiogram, please? Because we are seeing now the intervention part. We just want to see the diagnostic.
Yeah, sure. So could we stop that? David, could we get the slides back? Thank you. Oh, slides coming back. You can explain it.
Just the diagnostic image, please. So while you are getting there, I mean, because we've seen some of us have seen the case yesterday, so let me just ask the panelists while you are fixing the images there. So I'll start with you, Dr. Hadi, because I know that you've seen the image. So this is a CHIP case, high risk, but indicated BCI. This is 78 years old, who's, diabetic, hypertensive, also with chronic kidney impairment, normal ejection fraction, who has a CTO of the right coronary artery, and distal left main, and probably a mid LAD. We've seen that. So how you take or how you approach this case?
Well, thank you, Hani, for sharing the case with us. One of the intriguing thing about it, that the presentation of the patient was during the treadmill.
Yeah.
So he had a treadmill
Doctor,
with extremely positive. Yeah, we can hear you, Hani.
okay, so I'm going to pause here and basically summarize very briefly recent onset angina, acute coronary syndrome, and the risk factors in the background. Heart MDT resulted in shared decision with the patient and the team that we're going ahead with BCI, starting with the culprit vessel, which is the left system. And as Francis said, we can stage the CTO to the right coronary artery at the later stage. We're going to stop there. We have a catheter 6 ABU35 via the right radial route. And our strategy is double wiring and the pre-dilatation and IVUS. And then I'm going to stop there, and we have some IVUS imaging if you are giving us the right time to get you. Back to you.
Okay, Dr. Hani, just we'll discuss among the panelists for just give us 2 minutes, and then we'll come back to you, okay?
Okay.
So the treadmill showed significant ST depression, and I believe that the patient was very symptomatic and his troponin was positive. Looking at the case, it's a CHIP case, as you mentioned. There is a CTO of the right, and I think rightly so, Hani and his team identified the distal left main as the culprit. So they're going to address that culprit, and probably most of us would agree with that. maybe some would say I would go to the CTO, open it up, make sure if it's subtends to a large myocardium at risk, it makes it easier for me when I do the left main so I don't run in trouble. But me personally, I would have done the same thing with IVUS management and guidance. But the mid LAD, I would be also looking at it, making sure that it's not significant while I'm doing that.
Okay, so also we have Dr. Shada Al-Alawi, I mean, she joined us here. Shada, in such case, when you have a distal left main and also an occluded right, so I mean, some of us will tackle the right first so you can work comfortably on the left main. But here, I mean, they decided that, probably because of the situation, the ST depression on the treadmill, also on the chronic renal impairment, that they don't want to spend a lot of time and contrast on the right. How would you approach that patient?
Well, usually with the ACS, we'd like to have a complete revascularization, but in this case, we have to have a backup in the right side. So that's why some of people, they would like to open the CTO before jumping to the culprit. But I think it's ACS, so the culprit is first, and then you can see if you can open the CTO segment later on as a staged procedure. So I will go for the left main BCI.
Same thing. So we'll ask with the right side here about the role of imaging. I mean, they have mentioned and they're going to do it now. I mean, how would it help here in the situation? Anyone?
Okay, are you back to us or are you?
No, just give us 1 minute and...
Yeah, sure.
Thank you for the invitation. It's good to be here. A tough case, certainly, but I think it's left main. It's an ACS, so imaging for me is crucial. So I would do imaging, could be OCT or IVUS. I personally prefer IVUS for the left main. While I'm a CT operator, I use more IVUS than OCT. But also to see the ostium of the left main once I put the stent in, because we know when you work on these cases, you also can have in about 8 to 10% compression of the stent at the ostium. So I think imaging is crucial in this case. As a CT operator, I would just argue, if the right, I didn't see the anatomy here, is an easygoing case, I would rapidly do the CT of the right, because it gives me a little bit more of support, but then go to the left main. But I think it's not wrong to go with the left main. The patient has a good LV function.
Okay, so Dr. Hani, I mean, we still, this is a good image now. We can see now the angio, where you show us the distal left main there.
A very important discussion in 15 seconds. I'll tell you why we're starting with the left main rather than the CTO. And Francis is the director of the CTO program. Francis?
Yeah. Okay.
We cannot hear Francis. We cannot hear him. Hani.
Go.
Hani.
I think.
Dr. Hani.
Okay. You can't hear me?
We cannot hear him, no. If you just tell us what he said.
Right. So Francis said it might have been reasonable to consider PCI to the CTO first if the patient has an impaired left ventricular function and has features suggesting antegrade canalization would be possible, but with preserved function and clear culprit, the ability we can do that at a later stage is probably the preferred option. So just to avoid any delay, I'm gonna take you through what we have done. So Karen, if you get us through. So what we did is we double wire the circon LED. Surprisingly, really wiring the LED was not straightforward. There was a bit of accumulation there. We managed to wire it, add it next. And you can see that there is also, importantly, a moderate bifurcation mid-LED lesion, which will come to the equation in a minute. The next and next. And as you can see, we have just wired and then we did a quick pre-dilatation. Then I'll pass on the IVUS. You bring the IVUS, Scott? And I'll get the IVUS.
So you dilate it there in the left main.
You dilate left main with a small balloon just to make a track. IVUS, go ahead. Can you see the IVUS?
Yes, we can see it.
Yes, we can.
Right, I'm going to just change this for a minute. So that Mitchell, like, Francis, to the IVUS.
Thanks, Han. Give me. Or not. It'll. We're fully now.
Guys, Icon, can you fix the sounds from there?
There. I can want to see more, but I think I felt that's so significant, strong, see training.
So, as Francis summarized, you know, the mid-LAD proved to be significant, minimal human some minor calcification. There is calcification in also the distal left main and the critical lesion, as we see. So we are committed now to do the mid-LAD and the proximal bifurcation if circumflex. So we're gonna go ahead unless you have any thoughts that you would like to share with us or within the panel.
Okay, just continue working and we'll be discussing here also. So,
Hani, I was just wondering, you decided to do the balloon angioplasty before the IVUS because you had a hard time putting the wire in, or you tried to put the IVUS in and it did not pass?
We did try to put the wire. It was really quite difficult because the lesion was very severe, Paddy, and therefore we felt, you know, first of all, we're not live and need to wait. So for that reason, it'd be easier for us to do a simple balloon dilatation to facilitate the IVUS crossing, and that's what happened. And luckily, we're still in a stable situation. Okay. So now, if I go forward, so once we did the IVUS, which was very, very helpful in terms of left main interrogation and mid-LAD interrogation, this is the IVUS. And then next, and as you can see, also, we are now having 3 wires, LAD, CERT, and diagonal. And then the next step will be perhaps to pre-dilate the mid-LAD, stent mid-LAD, and then have a back-to-back from the left main into the mid-LAD. Okay? So the question perhaps the panel may wish to discuss within yourself while we're doing that is calcium modification. With the IVUS image that you had, what do you think is the best modification strategy here? Is it rotation? Is it, could you show the IVUS stent? Is it shockwave glycine? Or is it going to be just to see balloon 1-to-1 and correct the calcium or not? So that's what we are considering. So what's the balloon?
Yeah, it's clearly actually you can see focal concentric though calcified lesions at the distal left main. So probably you don't need a rotation. You'll be okay with the IVL likely. Though you have to keep in mind there will be hemodynamic compromised during the long inflation because they're gonna actually block both the LED and the circumflex. So I think I will use in this case IVL as a debulking strategy.
It's called growth.
Yeah, I agree with you that IVL probably is a good choice. Of course, you can go with Rota also, but you can get still good result with the IVL, and you can do it quick. So in the left main, so you can give the pulses fast, and then before the patient deteriorates.
So just what are you using, Dr. Hani? Just tell us what you have used now.
So this is a 3O non-confined balloon by 15. We use it to pre-dilate the LED and also the, Could you give me the cranial view so I can go back with this?
So are you going to use any debulking device here, or?
Are we going to use any debulking device? We're not planning at present. What we will do, we'll see with IBIS what did the balloon did in terms of the calcium, and then we'll take it from there. And I have some problems.
You know, the balloon dilatation, actually, it was fully balloon.
It looked like fully opened there.
Yeah, full opening there, so.
I lost the wire first.
One of the issue is on the IVOS you saw that most of the calcium is eccentric. Although you have also, I think at one part probably a calcium nodule or part of it. So I think rotablation would do anything. So you should not use rotablation because you have a wire bias. You will not touch the calcium. And well, the eccentric calcium, today we do not know what is the best, because with ballooning you just, an eccentric nodule, you just these places, but you do not change it, and you should change it in the composition to enhance the compliance of the plaque. Perhaps IVOS in this situation could help us, IVL could help us to solve this problem, because at the TCT, Akiko Mahara showed data of late stent recoil, and eccentric calcium is one of the strongest predictor of late recoil of stents when you do not have a high radial force. So also the stent selection will be important in this case.
Okay, so Dr. Hani, you have 3 wires now?
Yeah. We have 2 wires in the circon LED, and I just managed to pull out the wire from the diagonal, and I'm trying to go back there. But once we do that, we will hopefully be able to repeat the IBIS, and then we'll take it from there, okay? We can actually also, you can see the LED wire is struggling to get through that lesion. So what I am suggesting we do, we go cranial, is that get the IBIS ready, and regardless we can do with the IBIS study there. Okay, that's fine. That's probably the small diagonal. So I'll get that here. And we'll get that one here, still in the cranial, yeah, that's cranial. So we'll go down there. So let me just push that down and fraction here, and then we'll do that. Oops. Okay, no, okay.
I think one reason more in this patient to use IVOS is the impaired renal function. So doing and be able to do cases without contrast and just based on intracoronary imaging is very important in such patients.
Okay, that's perfect.
So I've just one comment. When we see the wire is not behaving very freely, you know. It's always going in some kind of calcified segments that will hinder the wire to advance. So not just to, and I have seen on IVOS more than 270 degree of a calcium ring there in the mid LAD there. So not just modifying the lesion, but to, clearing the way towards the lesion with the rotablator will also be very helpful. If I have any difficulty in bringing the wire down, and if I have a ring more than 270 degree, not just modifying the LAD ring there, but to have a better, a modification of the superficial calcium up to the lesion may also be very helpful. And then going there with scoring balloons would be my approach here, I think. But going with a non-compliant balloon is also and to test the lesion, it might a little bit makes the procedure a little bit longer, but it's also a way to do it. And the left main, I haven't seen that much calcium. There's an eccentric calcification there, but the problem is there in the mid-LAD, I think.
Just get the wire in the circ.
Okay, so Dr. Hani, now what you're doing now? So you have the IVUS catheter?
Right, okay, so could you give me an HC, please? Because we... Let me just get that. Yeah, I'm just trying to get the wires.
Yeah, that's lost the
Wire again.
Okay, that's fine.
But let's do the wires.
Yeah, that's it.
So we're gonna now show you the IVUS, and perhaps I might pass to Francis my headphone because we're struggling with your sound. So now with Francis, on you go.
Yeah, thanks, Hassan. So we're just doing an IVUS pullback in the mid-LAD after a 3 millimeter non-compliant balloon to pre-dilate. Just floor there.
Can you make the IVUS image on a big screen? Yes.
You can see the screen.
Yeah.
So that's kind of after 3. It's kind of different more altitude here of piece. And here we are. And we appreciate that this video is just First, 8, 2, right. You yes. Honest. Go. Please. Just be that. So that's 3 of the act. That's act. And 4. And this and that 3 of
We still cannot hear you, but we'll discuss the IVUS image here.
But you can see clearly here the behavior of this is, I think, a 3.0 non-compliant balloon to the distal left main with the osteoid. So the behavior of the balloon is very favorable actually against NATO, like I mean, to do debulking, for example, with rota. As Dr. Ziad mentioned earlier, like I mean, the minimum diameter of the even the calcified lesions is more than 2.5. So the rota here is not going to be very effective. So non-compliant plus or minus, like I mean, IVL is probably ideal in this case because of the behavior of the balloon as well.
I think also the mid-LAD lesion is was not that favorable as distal left main. I agree with Abdurrahman that distal left main probably does not require debulking, but mid-LAD might need the IVL, I would think. Maybe starting with mid-LAD first, then going to distal left main.
Do you hear that, Dr. Hani?
If you could repeat that, and I'll repeat it to the team here.
So the panelists here think that the mid-LAD probably needs debulking, probably with the IVL, but the distal left main, the NC balloon did some job there.
Yeah. So, the team in Dubai was considering IVL for the LAD, and but we feel that the left main has already been modified.
Usually when I see this circumferential calcium and I don't want to do rotablation, I use blood modification balloon before I go for IVL.
Mm-hmm.
It helps a lot.
Which balloon? Which?
Angiosculpit, cutting balloon, whatever you have. Yes.
Okay.
So what's your next step, Dr. Hani?
So we're gonna score flakes in the LAD, the cranial, please.
Yeah. And
What I'll just do that. Then before we step, I can go back with the, can I have a cranial, please? And just to try to get that, the cranial captain. And
Actually, the question is, what can we do when we don't have IVL in this case?
Okay.
Is there any other option? Is there any other solution we would like to do if we don't have IVL in cath lab? Should we leave it like that, or do we have other options?
Well, it was
That's my
mentioned
question
that
to everyone.
What would you do if you don't have IVL?
So actually, I don't use that much of IVL. So I'm a fan of scoring balloons, cutting balloons, and if I do not get my guide extension down, that means, and if that means there is a lot of problem, then I have to clear the way, and the best way for me to clearing the way downwards to the lesion and inside the lesion is the rota. I'm not using just rota, for debulking the lesion. I'm also using rota because this is a long calcification. We have some superficial calcium on the way as well, and somehow it will clear the way towards the lesion as well. So then it might be not that difficult to put a guide extension down and then go with a cutting balloon, scoring balloon. But I use mostly wedge NC balloons, scoring balloons, non-compliant, long balloons. That would be my approach. So we did it, the IVL story is not that much. For how long have we the IVL? So before that, we still modified the lesion somehow. So
Dr. Hani, what's this balloon?
This is a cross-flex balloon, cutting balloon process, and a 3 by 10 chromatic, and that's what we just define the region. As you can see, actually the balloon is straightened very nicely there.
Yeah, the last image looks that the balloon fully expanded there.
Yeah, and therefore I am going to have some light on the table, please. I, with the team here, are to go ahead and perhaps stent the mid-LED. Yep. So according to the mid-LED by IVES, we are going to put a 3 by 28. Okay, that's good.
So provisional stenting for the mid-LED with the...
For everything, it's going to be provisional stenting, and with either sync or...
what about leaving it with drug-coated balloon?
I beg your pardon?
What about leaving it with drug-coated balloon?
Drug-coated balloon for which one?
In the middle part, the calcified one.
The mid-LED.
The mid-LED. Yeah, you could, but I think probably the LED property to secure it rather than drug-eluting balloon. The diameter is 3 millimeters, and therefore it's a healthy segment, and it's important to secure the lesion. I don't want to inflate or inject a lot of dye, kidney functions and all of that, but we identified that the lesion was not particularly disrupted. So we are going to go now with 3 by 58 and take it from that. So obviously what we would like to do is, I know that got important time, something like 15 minutes that can finish this case, so we will try to do that. And I'm asking the panel and Dr. Mutayari to give just 5 minutes to wrap up at the end for the very point all of this. Mitchell, can you hear Mitchell speak? Mitchell, can you speak?
Cannot hear.
You hear? No. So what I suggest, somebody come and give Mitchell my headphones while I'm doing this. There is nothing terribly.
Hi, thank you. So just to update where we are, so we've, as we'll spot, just with the not compliant with the mid-LED did not delay nicely, so we've gone with scoring, but we're happy with the expansion. We're going to proceed to stenting this with by 20 design stent.
So what's the stent here, the size and the length? And
It is a 3 by 28 size, and then size that out, and then thereafter we're going to then do a 1-to-1 non-compliant treatment of the calcified vessel length.
It's 3 or 28 Zions.
I read the size, but I didn't hear what's he said after that.
Yeah.
So thereafter we'll go with a 1 non-compliant treatment of vessel length, and we plan with a 4 by 33 lines that overlap approximately out to the occipital left, and then thereafter, we've already measured the length of 4.5 millimeters, so we'll post down 4 millimeters length with a 4.5. So there's the nicely expanded 3 by 28 size. Patient's very stable, ECG normal, pressure's good.
It's expanding very well. I mean, there's no doubt that whatever happened with the modification, with the simple balloon, with the angio, score balloon, everything is working out. You didn't.
Yeah, absolutely. So I think taking that additional step up now, going with the makes a difference in this case. So now what we've done is we're going to take a 4 by 33 Zans, overlap approximately decent, and get it out similar next thing.
What's the size of the left main on IVUS?
So the left main and IVUS at maximum is 4.5.
4.5. Okay, and the proximal LED?
The approximate is 4.
Okay, good.
That makes it an easier match, actually.
Yeah.
Just
So
how much contrast you used in this patient with the renal impairment?
so far we're going to use, we use 60 mils of contrast.
What?
So we're trying to limit that, have as much as possible at IVUS guide to limit the angio with it.
it will be nice to see an angio now after the stent deployment, right? It's just,
Well, I will keep the angio at the end,
At the end?
because of the.
Contrast.
They have the. I'm sure that they can use the IVUS again after stenting.
Yes, we are.
So if there's any.
What we're going to do now is we're going to take a 4 millimeter blue, just gently dilate the proximal this LED stent, and then we're going to further use this.
Okay, we have one comment for a question from the audience.
Is it safe to leave the diagonal wire under 2 layers of stents?
So that's seems good question.
I think this is the time to think what to do with the diagonal wire.
Yeah, so I think that's a good question. So what we're going to do is, just as I mentioned, we're going to further dilate the distal left main, proximal the stent. I think if the diagonal is not compromised, then we'll remove the diagonal wire at that to prevent a long segment of field wire as suggested. Excellent point.
so he's minimizing the contrast to the minimum. Though the EGFR is not that low, it's in the early 50s, I guess.
Yeah, it was not.
So could we hit from fractal buttocks?
So just dilating or expanding the stent here.
Yeah, Dr. Hani, there was a questions here in the audience if you need to keep the third wire, which is in the diagonal, behind 2 long stents. Should you remove it or still keep it?
Sorry, I didn't catch that out. The problem is that I've just explained to you.
It's going very nicely. Okay, 1, 2.
So just to explain to you, we are struggling with the voice because you only hear one down on headphone, so that's why we changed this headset between the 3 of us. Now, just to explain, as Mitchell and Francis said, we have stented the middle LED. We're trying to be cautious with our cranial position. And we are now going to start stenting the, can I have some light, please? We stent the proximal or the left main stent with, let me just ensure that I have this. So we'll stent the left main stem, and then we will take it from there, and that will give us some security where we are, just trying to ensure that these 3 wires are not wrapped and we are in a reasonable shape.
So, Dr. Hani, Dr. Hani, the comment here, are you comfortable leaving the diagonal wire there, or are you going to remove it?
I'm not comfortable. I am absolutely confident 100%. I don't have a problem with that at all. I've never tracked, I have never lost a wire in 30 years of interventional cardiology. So that might be the first one. And there is no arrogance. It's purely what I have to do. So I don't have a problem with that, but that's that in the life case. Okay, I'm gonna get that. Thank you.
Okay.
Yeah, perfect. So I'm gonna get the stent.
But normally what we do, probably all the panelists, you put the stent at the bifurcation of the LED, and if you have to put the stent proximal, you pull the wire back at the diagonal just to safely make sure you can pull it out safely later. And if you're still worried about the diagonal, you can recross again and do it. I think that's probably what a lot of us would have done, but it will be interesting to see.
Flow is not, especially if the flow is not compromised now in the diagonal.
Exactly.
So,
The diagonal. So that's the LED. Yeah.
So you are now putting the stent in the left main?
So that's the LED. Yes, we are. I think that's the LED. Let me just make sure that LED, that's the LED. Can you go down for me, please? Yeah. I think that's the diagonal. That was the LED. Yeah, that's the LED. And then go stay there and then cross, do the overlap, and then we look at the ostium of the diagonal, and then we'll take it from there. Okay? So do you have any comments or anything you'd like to ask the team here? Because we are just about to deploy that and give you some assessment, and then we do the thought and all of that. If you are happy to wait for us. So let's just skip that here and see it. That is here, and that is here. That is here. Okay, fine. Let's take that going down in area there.
Just one question.
Now, okay.
A question
Let me stay there.
to you, to the operators. So what kind of stent do you use? Do you use a special stent for left main?
So for the left main on this occasion, based on IVUS, we're using science. Sometimes the left main is very, we have the Megatron, but at maximum time, think that the diameter of the left main will allow expansion of the science in the left main to ensure that we're on the right track. Okay, so that's where we are. And let me stay with that. And then let me just stick with that. Okay, fine. You have a stent vis, see the, okay, stent vis for me, please.
So this is a 4O Zions, I think?
This is a 4O Lions. I think they are aiming also for a short overlap with the first stent.
Dr. Hani, regarding the left main stent, do you need to come back to the ostial left main?
It's a lot.
Or because it's short left main and you need to do pot, so you have to come back with enough length?
Actually, there's almost 1 centimeter. So we're going to perhaps just go into, yeah, here is, and perhaps we go to, let me just take that. Could you go left cranial, please?
It would be nice to do a stent boost here, actually, just to...
Yeah, we've done a stent boost, and that's it. You might not see on the screen, but we are overlapped, too much overlap, so we'll come back.
Back is.
Do you have overlap with the first stent?
Yeah, we do have overlap first stent, so just see if the ostium is dead. That looks okay. Watch out. Okay, yeah, that's fine. No, still this for me, please. Epicodal.
انه راح النيوكرينيال وذكرين بشكل يشوف الآن.
The hanging wire in the aorta doesn't look good. I think we have to straighten it before stanting it.
Yeah, I think
Don't worry, take that out. Just shortly, we were discussing that, so it's not a problem with this.
It might cause some kind of stuck there.
Sure. Overlapped. So let me just take that apart. I don't like when it's the radio peak marker is there. So, yeah, now. Okay, let's just ignore that. So what I will do is just try to take that diagonal wire out. Yeah, okay, so let me just take the straight wire first. Straight wire. Is that the diagonal? That's the LED.
it is the diagonal one, the one, no.
Both cranial.
Sorry.
So let me take that diagonal out. Out. That's the diagonal there. Okay, diagonal. You take that Sasha. Okay, and then let's take that here.
So diagonal wire is out.
Yes.
Correct. Yeah, it was not picked out in serum because the position was not right. So
Yes.
we'll stick this here. Yeah.
Probably if you don't gel the
Back of fraction. Yeah.
radio opaque parts of the wire, you're okay, usually.
So how you're deciding the position of the stent without contrast? I mean, do you know? Okay.
Yeah.
Like that.
Yeah.
Happy then? Go back where you're happy. Happy then? Okay. Okay.
Yeah, this projection is probably the best one.
Yeah.
It's
For all of us.
Yeah.
I think leaving the wire in the diagonal just when you advance the stand is a good thing because you have support, because it's trapped, and then you take it out like they showed now.
Yes.
Yeah, me too. I leave the wire there just to have a better support in order to bring the stent there. So if you're leaving a wire, I'm just not comfortable with leaving a wire under two stent struts. So you are doing a left main calcified lesion. Okay, if it might not be happening in 100 patients, but I have done one, we can dissect also all the way back. So I think you can leave the wire there. It's not a nasty thing. And you can unravel the wire as well. So these are the complications I have encountered. So therefore, it's better to take it out, I think.
That's it.
Right. Okay. We're now doing a part with the 4.5 by 15 balloon, and we would do just the left main, ensure that we're on the right track. Remember the overlap, there's a 4 into 3, so that 3 millimeter stent has already been, that outflow has been nicely, and you can see now the 5 go very nicely there, which is good. And then let's see what that is. Yeah, that's the bifurcation. Just give me a 12 there, or 10, and then up back.
So then here comes the question, who's gonna open the struts of the CX?
Let's have, we will see what it looks like. Yeah.
So what's the question?
So Dr. Hani, there is a question, we'll ask the panelists here. I mean, who would open the struts to the cervix?
Yeah.
If there is no
We don't
back
do
shift,
it
nothing.
Routinely, no?
We don't do it anymore. I mean, when you do bifurcation, whether it's lift main or whatever, opening the strut is not going to gain you a lot more than distorting the stent itself, and you might get actually with a dissection from the balloon itself. So I'm not sure there will be a great advantage doing it. But while he is doing the part, I was wondering if Hani wanted to do another part for the bifurcating LAD and the diagonal too.
Yeah. We're obviously considering that. What we are doing now is just giving a platform for all other devices to go in. If we want to do kissing, if we want to do further pop distillate, all of these, we're just mindful of time. Can I have some nitro? And I would like just to show you, because we haven't been taking any angios during all this procedure because of obviously the chronic kidney disease. And therefore, we'll just give you something just now, see how that will look like, and then we'll take it from there. Okay, let's just get you a better plot here, and that's it. And then still this pinched, not much. Okay, and cranial view, please.
Now maybe you think about opening the struts in that circ.
I'll tell you in a minute. As soon as I have a better idea, I think that looks okay.
Very tight. You talk tomorrow.
Diagonal looks okay here.
The diagonal looks absolutely fine. What's that one?
I'm wondering about the ostium of the circumflex.
Maybe we
If
can
there is
look
any
at
black shift there.
Yeah, there is hazy area just juxta ostial of the circ. Is it like congealed or thrombus or?
What we have to do when there is ambiguity, here will do an IBUS. That will give us an idea that the left main, mid LED bifurcation, and also a piece of the ostium, the circumflex artery, and then we will be well informed about what's needed based on IBUS rather than just a angiogram. So the rest is having simple manner, but we'd like to have 5 minutes, if you don't mind, and to do all these nice educational here is you. Okay.
We have 7 minutes on the screen there. I mean, you have 7 minutes to do IBUS and in the meantime, I'm going to ask just in the audience to show hands. Who's going to consider doing something for the ostial circumflex? Okay.
I think
we'll ask them again after the IBUS.
Sure.
I think we can look in the spider view.
Yes, we can see the IBUS. This is in the this is in the mid LED, right, stent?
Yes, put it. I'm gonna pass on to Francis, comment on the IBUS.
Thanks. Then, well, we
well, looks well opposed, expanded. Francis, we don't hear you very well. The microphone is not working.
Look well up and the air now is look to be very acceptable as to reference. Yeah, growth. There we are. The team appreciate again not post that section, but to already see between first there that point. There, posting. Got up the off with the other short.
You can see that area between 8 o'clock and 12 o'clock in the left main. It just does not seem to be well deployed. You agree, Mohammed?
Yeah. The stat looks to be opposed. The area is yes, no rate about 30.4, which we know the no drop associated with 0% risk of heart these 5 years. So a little bit of work to do with the LED post-station, maybe a little bit of work the ostium, the left main. Otherwise, I think it's pretty resolved with a bit more work to do.
So we didn't hear Francis very well, Hani. So
sorry.
Francis, we couldn't hear what he was saying, so can you please just tell us?
That the cross-sectional area of both the left main and the LAD are reassuring. We are actually currently measuring it, and you can see in the left main is 15.5, and above 13 is the evidence base that it's very low complication rate and excellent long-term patency rate, and therefore that's very acceptable. We might do offline some dilatation for the ostium of the left main, that is in the middle of the AD, but these are kind of the final cuts. But I think that we are very happy with the outcomes now. I don't have any concern regarding the ostium of the CIRC. I've asked my team and colleagues here, are you happy with the CIRC, Mitch? Okay, we'll get a spike you just to make sure that we are not leaving anything.
Yeah.
Okay. So, you know, before we conclude, there might be some final touches we can do it off camera, but I'm keen to hear any comments from the panel before we give you a educational learning objectives. Take it from there. Hold on. Okay. To you, Dr. Mutayari. Here's
us to comment.
We need to ask him about the CIRC austere.
So let's have just a short comment from each.
Yeah.
Okay, looks fine here.
But yeah.
It looks fine. So I'm happy with the result. And
I think the CIRC ostium is not compromised. Maybe there is a thrombus shift just to the proximal segment of the CIRC. Looks good, Carmi.
and this view looks actually better than the previous view.
Yeah.
It seems to be a mild carina shift to me. I agree with you. And what the beauty of imaging, actually, Mohammed, is, you know, you get the 15.3 millimeter square stent area, and you're not worried about the I would say, under expansion on the, from 8 to 12, which I mentioned. I mean, you cannot see that except if you do imaging. That's a great value.
Any comments here?
Yeah, it's a beautiful case. I think it's a carina shift rather than any sort of compromise to the austere circ. But yet, I could send an IVUS to the circ just to make sure. This is what I would do.
So, Dr. Hani, I mean, people here are happy with the result with the left main and the LED. What's your plan for the RCA?
The RCA, I think what we will do, we will wait for a few weeks. See, remember, this is a 78-year-old male, so we could easily bring him back for decanalization of his right artery. That would be largely depending on his symptoms and optimum medical appropriate secondary preventive measures and evidence of reversible myocardial ischemia. If he was 55, 65, we would bring him back any case of complete revascularization. So to summarize, we are considering CTO, RCT, pending his progress and his wishes as well.
Dr. Hani, how much total contrast did you use? Because we barely could see like 3 angios. So congratulations.
Yeah. He has a question for you, and 78, 55 contrast. Yeah.
That's before the live transmission, probably the diagnostic part. And thank you.
No diagnostic part was a different day altogether. The diagnostic part and the PCI to the on this table in this occasion, it's only 85.
Any question? Yes.
Considering the origin of circumflexing severely calcified left main and osteoproximal LAD, I want to know your opinion about using gelled semi-inflated balloon technique in this setting, since if you have already placed a wire, but considering its retroflex origin, if you won't be able to cross it in case of plaque shift or calcium shift or carina shift, is it not safe to place a balloon in the circumflex small semi-inflated, semi-compliant balloon and simultaneously inflate it? We call it gel semi-inflated balloon technique. And then remove the balloon, inflate the stent balloon again, and then do the pot and put the wire in circumflex. This way, you can save the side branch, and there is minimal chance of carina shift or plaque shift.
Okay.
Yeah, he's asking about a jailing balloon to the side branch. So, and like, I mean, this, like, I mean, angle, it's more than 90%. You don't need, like, I mean, if you have, like, I mean, narrow angle of the side branch, like, I mean, less than 45, yeah, you can think actually about a jailed balloon technique. But in this, like, I mean, angle, no, I mean, I don't think, I mean, there is any.
And my guidance principles: keep it simple. Do it if you have to. Don't keep footering about and recrossing and reballooning. You may complicate things, disrupt that. So with our extensive experience left me in here, you're talking about, the Nobel Mitchell run the Nobel trials for ethylene stamps, and we have extensive complex experience there. And we're not happy to leave the hospital set. We're ecstatic and delighted and very pleased to leave the listing and the circumstances. Right, I'm gonna take off my mic.
Hani, at the end, I just want to thank you and your team for sharing this tough case with us and being with us this year. And hopefully we'll see you in the future.
If I may, if you give me a second, that's special.
So, again, thank you very much for allowing us to show this case. So, there's been a nice demonstration of left-hand additional LED diagonal application with at least moderate calcification of both lesions. Imaging allows to limit the contrast use and also use fairly simple technologies. You could see that actually non-five lesions and scoring wins were satisfactory, like extended expansion, and you could see a final output showing very good extended expansion, very satisfactory minimum stent areas. And this is all done with less than 1,000 contracts, basically very stable throughout. And once again, thank you for your time.
Okay, thank you very much. Excellent job. Thank you.
Go ahead.
Yeah.
Goodbye.
Thanks to the second part, the for delivering a very good patient, given the patient a good outcome, secure outcome, PCI good, and we can reassess the options and symptoms.
So in spite of all the minor difficulties, it went very well. So
yeah. The global play team woke up at 4 o'clock this morning to deliver this. So I'm going to ask you to look at the camera, and I would like the entire all at the panel to give them her applause around.
Thank you, Hani. Thank you. Okay.